Welcome everyone to today's webinar, Using Digital Platforms to Drive Network Value for Healthcare Organizations. On behalf of Becca's Healthcare, thank you so much for joining us. Before we begin, I'm going to walk through a few quick housekeeping instructions. We will begin today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer section. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. If at any time you do not see your slides moving or have trouble with the audio, try refreshing your browser. You can also submit any technical questions into the Q&A box. We are here to help. With that, I am pleased to introduce today's webinar, Kristen Valdes, founder and CEO of b.well Connected Health. Again, thank you for joining us today. And with that, I will now turn the floor over to you, Kristen.
Awesome. Thanks so much for having me. Hi, everyone. I'm Kristen Valdes, founder and CEO of b.well Connected Health. We are a digital health platform that helps employers, payers, health systems, and retail pharmacies with the reimagined consumer experiences that they can provide to the populations that they serve. Today, we're going to talk a little bit about 2023. Just a quick year in review. When we look at the massive changes that have happened across from really 2020 all the way through, 2020 all the way through 2022, we saw really banner regulatory changes trying to create a quote unquote shoppable healthcare consumer, starting with major rules like the information blocking and interoperability rules that gave consumers the ability to collect and aggregate all of their healthcare data through any trusted third-party application of their choosing. This really forced healthcare onto the cloud, to mapping all of their core data elements and systems of record into an open API infrastructure. But it wasn't just information blocking and interoperability that started to create the shoppable healthcare consumer. Other pivotal rules came out, like price transparency, the rollbacks of things like anti-kickback and safe harbors that actually allowed consumers to start to create digital incentive programs in order to align people digitally to loyalty programs, things that they experience in every other aspect of their lives. Now we're on the precipice of new rules that are coming out, beyond the 26 different regulations that have created pathways towards consumerism in healthcare. In 2023, we're seeing that the government is doubling down, trying to not only help consumers have free-flowing information to select applications that could be valuable in their healthcare journey, but also in the monetization and the movement of programs that help consumers to not just select and aggregate their data and choose who they can share it with, even outside of the HIPAA protections, but also the ability to select where their premium dollar is going through programs like ACO REACH, which are a really nice way to get the remainder of Medicare fee-for-service into a value-based program beyond Medicare Advantage. But the changes for 2023 are coming, and they are just as big and impactful as the ones that we have just lived through. As an example, we saw that there was a renewed and increased experience rating measure for HEDIS, and in particular, the STARS ratings programs. So payers are now understanding that the CAHPS survey is something that is very hard to affect historically. And consumer experience measures overall have now moved from a 1.5 weighting to a 4x weighting for the 2023 plan year. The CAHPS surveys are things that are going to require all of our payers who participate in these programs and the value-based contracts that they have downstream with their providers to focus on consumer experience metrics. These are a little bit harder to manage and measure because you really need to understand a consumer sentiment in real time and be able to affect that before surveys go out from the Medicare program to the populations they serve. Some of these questions are things like, at the time that you felt like you needed healthcare, how fast could you get that care? Or at the time that you felt you needed a prescription, how fast did you get that medication? Did your most recent doctor's visit start on time? So these are things that not only are not commonly tracked, but they're also really hard to measure. And we don't have in our existing systems of record the ability to measure consumer sentiment and to react to it in real time. We're also expecting another rule drop before the end of the year something called the Reduction Burden Act. And this is going to really impact the way that prior authorization works in this country, requiring payers and providers to start working together. And therefore, we're going to talk a lot today about a platform. What tools and architectures do you have in place today? How can a platform support these new business models, the new integrations that you need to have with partner systems all across the country and other types of solutions in order to meet what the consumer experience and expectation is going to look like, so that you can get prepared and get ahead of where the monetary puck is moving. When we think about appointment times and convenience is absolutely winning. The reason for that and the reason for these movements in measures is because we measure and track as a country the average time it takes in order to get a doctor's appointment. And we are at an unprecedented level of 26 days in 2022 in order to get a new provider. So we need to think about convenience as we start to move towards these experiential measures. If our monetization of the healthcare system is going to start to rely on increased weighting on consumerism and consumer experience. So when we think about other areas of our ecosystem and our day-to-day lives, more and more often our digital experiences are personalizing to us, right? Netflix as a good example. I think during the pandemic, even people who were not familiar with Netflix became familiar with Netflix. But what they recognized was that it was personally tailored to things that they watch, would recommend other solutions that might look like something that you might enjoy. So it uses intelligence levels, but down to a unique personalization. So consumers have personalization in their shopping cart experiences. You know, if I'm on the internet looking at a pair of shoes that I might think I like, when I flip over to my social media platforms like Instagram, that pair of shoes is going to pop up in my advertising, reminding me that it's something that I was looking at and that I might want to purchase. I'll soon receive an email into my inbox letting me know that those shoes might be on sale and that they're going fast and I might want to consider purchasing them. But healthcare doesn't work this way. We still expect healthcare consumers to show up and know that they need care, and then transactionally work within a system that wasn't designed around them, their needs, and their personalization, but was more designed around showing up when someone had a need, caring for them in an acute or episodic manner, and then releasing them back into the wild to manage their healthcare all over again. But the time for change is now, because consumers are no longer tolerating long wait times. They're frustrated by the fact that they not only can't get care, they don't know how much things cost, they don't know how much they owe or how to plan, even for the type of benefit for their families. And healthcare is becoming more and more fragmented. It's why you're seeing, and you may have noticed, a lot of different press releases recently. So one of the most frequent ones that I really like to talk about was, it was just in this past 30 days that MinuteClinic and Google announced a partnership where MinuteClinic opened up its APIs for the ability to schedule appointments. So anyone searching the internet, going to a Google, now if they're looking for a clinic or something that's open nearby or healthcare, MinuteClinic is going to pop up, but it's going to have the option to book an appointment directly through the Google platform. This is MinuteClinic's way of being able to be convenient. And for folks who don't like to pick up the telephone or might be multitasking or already on a phone call, but simply looking for care, it's their way of getting that new patient acquisition from a convenience standpoint and just making their clinics much easier to work with. We're now starting to see health systems all across the country who in 2022 and 2021 were really focused on getting their doctors onto online and mobile appointment scheduling, which we all know was not a technical transformation, but it was a cultural transformation. And it's been quite hard to do. In fact, most appointments booked in the US market today are still telephonic. But as we think about new entrants into the healthcare space, those that are disrupting primary care or are trying to go after convenience to become the launching off point for healthcare, they've recognized that by putting software developer kits out into the wild and opening up those APIs beyond their own existing applications and websites, that all kinds of apps and partners can simply bring them business for free. And so health systems now are starting to open up those APIs more publicly. Imagine a world where you can connect to APIs, whether it's for your labs, for your pharmacy, for clinic visits, for primary care, and competition becomes based on convenience. If we continue to focus on enhancing our existing portals and focusing on how long it's taking to get our doctors onto mobile scheduling, many of our patients and consumers are going to move towards more convenient options that can service them in the time frame that they need. And remember that a single no-show increases attrition rates by over 70%. So the race is now to think about loyalty, but it's really hard when we operate in a transaction-based setting. When we think about our existing portals, which have a great place in the ecosystem of overall healthcare services and are part of the unified platforms that we're talking about here today, they're meant to be transactional, but they all rely on consumers already having an encounter with the healthcare system or knowing that they have a need and presenting for care. The top usage of portals today is in finding a doctor, booking an appointment, messaging your doctor, asking for a prescription refill, or reviewing your test results, with the overarching broad capability of receiving patient payments being the number one feature that is available across all healthcare portals, followed closely by scheduling of appointments, in large part that are still mostly call to book, even when they exist within our portal capabilities. But we also want to think about things like it's not just about payment and appointment bookings. If we want to think about what consumers really need, they need us to bring the outside in and help to navigate them across their landscape. And what I mean by that is knowing somebody personally and anticipating their needs. So the information blocking and interoperability rules allowed for consumers to pull in and aggregate all of their healthcare data, even historically, from all of the providers that they see, all of their payers. So they have historical medical claims, and they're drawing that data outside of HIPAA, which allows them to share that information with whomever they feel can add value in their healthcare journey. So over the last 2 years, most entities were focused on how to get compliant because we know that there are some stiff penalties associated with not having those APIs available. But many entities are now flipping over to how can that data become a strategic advantage to me and my organization? And the answer is that it allows you to, with informed consent, have consumers share that historical information where you can get a true 360-degree view of an individual and their families with consent in order to use that data to understand where am I not servicing my consumers the way that I could or should be? Where are they going outside of my ecosystem where I'm not able to service them in the way that they need? How do I get to know them personally and start to anticipate their needs? And then from an automation standpoint, move beyond clinical call centers and use digital and mobile experiences to personalize communications to an individual all the way down to an N of 1. What's unique about these rules that I think goes undiscussed, quite frankly, out in the news and the media, is the speed at which data is now transacting. Historically, our entire healthcare delivery system has relied on medical insurance claims or billing data in order to do things like build predictive models on risk or cost, or manage population health, because it was considered to be the most comprehensive set of data that existed in the US market on an individual. That's actually now changing, with consumers' information being stored on average in about 70 different locations. And we are gaining more and more information locations for healthcare as we widen the kind of data that we're collecting and attributing to the healthcare ecosystem. But information blocking and interoperability did something very unique. They required that the API have the ability to transact data within 24 hours of an encounter occurring, with a few minor exceptions. But what that does is mean that we can, in real time, for the first time, not wait for a medical claim to be submitted and then wait 30 days for a batch file to come through, which is often 45 days delayed from the actual encounter or the reason that a consumer had an experience. And now within 24 hours, when it's relevant to the individual or their family, we can start to create use cases across platforms like, I see you've just been discharged. Are you having trouble picking up your medications? How can I help? Or I see your doctor wants you to follow up with home health care or maybe even physical therapy. You have X available in your benefit this year. Can I help you find a doctor and book that appointment? So you're more, from a relevancy standpoint, able to reach people in real time. Remember the example of looking for a cool pair of shoes and having it show up on my Instagram feed instantly. Healthcare now has the ability, from a speed perspective, using the patient right of access data in order to get to consumers faster and make better, more comprehensive experiences across all of the platforms that we have that deliver our healthcare delivery model and system in the US market today. But why does this matter to consumers, and why does it matter to our customers? Well, we're all chasing one thing: loyalty. We want to be the trusted resource that can care for all of the populations that we serve in our geographic locations, and many of us now starting to expand through telehealth and virtual care and home care, even beyond our existing local demographic areas. The problem is that we're still trying to use our existing systems to deliver those services. From a consumer perspective, the answer is very simple. The race to loyalty is whoever can provide a first screen mobile application that manages a family's healthcare all in one place, that no one has today. So imagine the core tenets of loyalty: giving consumers and their families access and transparency to all of their healthcare data in one place that they're free to consent and share with whomever they feel can add value to their healthcare journey, using their data to truly know them, to personalize communications and experiences through automations. Things like, your son Johnny is due for an updated tetanus vaccine. It takes about 6 weeks to get into your primary care. Would you like to book that appointment now? And being able to cross-pollinate information with access to services that can anticipate their needs and then navigate them to the kind of care that they need. Did you know if your doctor's not available, your pharmacies can now vaccinate? We may be able to get you that updated tetanus vaccine at the time that you pick up your medications this Friday. But then also being able to bring together the worlds of in-person, virtual, and digital into protocols where we can create convenient experiences for consumers. Like, if your doctor's not available for the next 6 to 7 weeks, where we know about 70% of people will abandon those workflows, here's the next available doctor who can see you. And all of that is integrated into your existing EMR infrastructure, because your EMRs are allowing open proprietary APIs that will provide the ability to bidirectionally pull and push into your EMRs. But that allows you to layer multiple technology platforms on top of your EMR and stack them together to a unified platform. So if the next available doctor doesn't meet your needs, here's a same-day e-visit we might be able to guarantee you. Or here's a telehealth visit that you can have right now. If this is more of an urgent issue for you, can I hold that place in line for you at the urgent care center that we have up the street? This one has the shortest wait time. So by creating protocols, you can actually start to look at folks who show up to your door needing care, looking like marketing conversion funnels. How can we start to meet their needs so that we can make sure that more people showing up who require care are actually leaving with the care that conveniently fits into their lives, regardless of how many core systems are underneath? When you look at someone's healthcare folder on their phone today, you can see anywhere from 10 to 70 different portals. And the problem is persistency. The only thing that is consistent in healthcare is the consumer. In our lifetimes, we change insurance on average every 2.4 years. We change our doctors, even when we're switching from pediatric care to adult care, and then along the longitudinal trend line into Medicare. We change our employers, so our benefits change. Everything about us changes, including even our technologies and our wearables. Fitbit was out before the Apple Watch. Many people switched. The challenge is that our data historically does not come with us. So when we terminate from one experience, our data ends there and it doesn't come with us. With these new rules for information blocking and interoperability with consumer consent, they can pull that data into a unified experience and they can carry that data with them. So the longer the longitudinal data is that we have for consumers and their families, the more we can know them, their habits, how they engage with healthcare, and we can start to personally know them. So we can start to switch from a folder that requires 70 or more different logins, portals, passwords, and we can start to give them a single launching off point to manage their healthcare. Because when I have access to my data, I'm getting personalized notifications. I am connected into convenient care that anticipates what might fit into my lifestyle. And then furthermore, using consent to create a framework where I can connect with my family, friends, and loved ones, because healthcare is consumed as a family unit in this country. 86% of healthcare decisions are made by women. So if we look at that healthcare folder on the left for just your own data, imagine that times the number of people that women care for in this country. They will have one of those for their children, for their spouse, for their parents who are more often aging in place and not living with them. Then they have to navigate portals and passwords and identity. And quite frankly, that's why a lot of consumers just masquerade online as the person that they caregive to. I'm a caregiver to a parent with health needs, also to 3 children. And I am the one who accesses their portals and unifies them and makes their appointments and gets them their care. And so I have to manage spreadsheets of logins, portals, and passwords. And so when we think about how platforms can be beneficial, starting to think about new tenets like identity that we'll talk about in a moment to make this easier are a new way of thinking beyond just the existing workflow systems that we have today, but how we can layer and stack them all together to create a unified experience where the user doesn't actually have to know or care how many backend systems are supporting their experience, and we can focus on the experiences themselves. Getting to a true N of 1 requires that you know the human. And what that means, down to knowing me personally, is that you need to understand not just my experience with you. We all have great clinical data sets for the encounters that someone has with you and your organization. But we need to go beyond just medical records of our encounter. We need to be able to move into the patient right of access, which means that we can access medical data from outside of our system, creating a more holistic picture. But we also can pull down and get access to data from a health insurance or a payer perspective, so we can see where people are submitting claims, where they're spending their money across the entire ecosystem. But also uniquely connected is Medicare fee-for-service and the Veterans Administration, who actually went early into the open API infrastructure and realm. And so third-party applications have the ability to pull their data across multiple systems. We all know that there can be sometimes not just a singular insurer or payment pathway, but there can be multiple. You could be covered by, commercial, the VA, and Medicare and Medicaid all at the same time. So it's particularly important, that as we switch between Medicare and Medicaid, or we switch from, commercial to Medicare back to commercial, or that we have our VA benefits that are layered on top, that we also have information into everyone who is paying for care and where those services are performed, but that we also gain access to labs and pharmacy data, wearable data, and consumer-generated data, like the social determinants of health, health risk assessments, goals, things that we know people are trying to accomplish. But more and more importantly is their preferences. Do I prefer telehealth if it's more convenient for me because I travel quite a bit and I can't really guarantee when I can, make an appointment 6 to 7 weeks out? Do I prefer to be in person because it's a chronic condition that I'm managing and I want to have a real relationship with my doctor? Do I prefer group therapy over individualized? As we think about consumers and convenience, they are all unique and we all have different preferences. The only way to get to a true N of 1 is to pull in their data and to learn from it. And why open secure data models are now accessible and possible to start to attach your machine learning and your data science. Training models on a user's full holistic picture allows us to learn better and start to anticipate needs. Whereas we bring together services from both inside of our ecosystem and outside of our ecosystems, we can start to deliver an experience that might look different person by person. And when you think about person by person, it might be, hey, happy birthday. It's time for you to have that colorectal cancer screening. Not everybody wants to come in for a colonoscopy. It's why it has been a ACO measure and a STAR measure and a HEDIS measure for so long, because it is the test that nobody really wants, right? But the reality is that we need it because the prevalence rate of colon cancers are increasing in our population. But not everyone needs to come in for a full colonoscopy. Many people can take advantage of an FDA-approved toilet water test right in the convenience of their homes, but still don't seek out that test. And many health systems don't have partners like Everly Health and others that can send that test directly to the doorstep of the human who needs the screening. So now we can create consumer pathways across platforms that say, it's time for your colorectal cancer screening. Dr. Smith would like you to book an appointment to come in, or if it's more convenient, I can send you that toilet water test to the home and you can drop it right back in the mail and we'll schedule you with a follow-up telehealth visit to review your results. Or I see you're picking up your medications from the pharmacy on Friday. The pharmacist is going to add a Cologuard kit to your order, answer any questions that you have, and you can drop it back off at the pharmacy or right in the mail. We'll make sure to get those results directly to your physician. So being able to meet people where they are, that we've been talking about in this industry for a long time, is becoming more and more possible as we start to know what people will or will not do. And now that we can create incentive and loyalty programs to align to care plans that physicians write by helping to encourage people to get a badge or a reward or some type of a monetary incentive or even a social giving campaign where they're seeing that there is an outcome for them taking actions and steps. When we think about loyalty programs, we're all trained to loyalty programs in a digital experience. I fly Southwest, I live in Baltimore and it's really a Southwest hub and the only airline I can fly, but I also fly it because I get to board first, right? It auto checks me in. I have a companion pass where my husband can fly free and join me in line. So it's convenient. Why would I then look to lose my status and go to another airline? Conversely, if we think about the technology ecosystems, I have an Apple Watch, I have an Apple phone, I have a Mac computer, I have a tablet. And when I do something on one of those devices, I expect it to show up on all of the other devices that I use in my life. So why, if I need a new phone or an upgrade, would I start with another platform that's outside of that ecosystem that doesn't connect? I wouldn't, because it's a friction point of starting over. So when we talk about the race to loyalty and the race to personalization, it's going to require a platform that exists on an open, secure data model that allows for data science and training to start to anticipate and meet consumer needs. And that will allow us to truly target loyalty for consumers, because once we've got them set up in our ecosystem, giving them everything they need, not just the services that you provide, but services that are all around them that take part in their healthcare journeys, we have loyalty and they don't want to start over. And that's where we're seeing our customers go in terms of trying to create that loyalty and convenience so that they can service all of a consumer's healthcare needs, personalizing experiences, not by marketing campaigns, but by automation of when stream data comes in, being able to immediately get that information out to an individual at the time that it is relevant in order to drive action. So when we think about platforms, platform is a very overhyped, overused word, right? But if you really look up the definition of a platform, it needs to bring things together and it needs to have both viral and network effects. So when you think about platforms, right, you have to start with the foundation of data, because data normalization and centralization across all of the different platforms that service your business today are going to help bring together the real picture. But it's actually building those data infrastructures and models around an individual, an N of one. So remember, we talked about identity. In healthcare, we have a huge advancement that needs to be done as we move into the post-internet era of healthcare. And what I mean by that is we have to know that the person behind the device is who they say they are, where oftentimes today they are not, as we talked about before, because most caregivers are simply masquerading as the people that they caregive to. Because through HIPAA, we've made it very difficult and full of friction to go in and work inside of family units for consent and consent management processes. But identity is particularly important because as we bring together different disparate systems, there's a lot of data that needs to come together. Many of you may not know, but there are 2,500 different Maria Garcias in Harris County, Texas, with the same birth date. So it becomes very complicated when you think about identity in healthcare, when the way that we confirmed identity up until this point was we would show up in person at a doctor's appointment, hand our driver's license and our insurance card over to the front desk staff. That front desk staff would look at the driver's license and make sure that the photo matched and make sure that the name on the driver's license matches the insurance card, and check, you are who you say you are. The challenge is when people come into digital or virtual for the first time, that there may not be true. And it's much harder to verify that information. So looking at your platforms and increasing your technologies to move to, somewhere close to an IAL2 level identity standard. There are programs that are being pushed out and pilots all across the industry in order to improve the identity, because identity is a precursor to patient matching, making sure that we are getting the right information matched across systems to a human. All of that logic can be done and become more intelligent in an open, secure data model, but it's much harder to do that when you are pulling and pushing into databases that are proprietary, supporting other systems, whether it's our telehealth platform that needs to be combined with an EMR platform, whether it's multiple EMR platforms that were acquired through M&A or acquisition that don't talk to each other yet. But being able to normalize all of that into a central location is important, because once you have the concept of a person, you need to think about the tagging of data associated with that person, because it's not just getting the harder problems to solve that we've been solving for the last few decades of, is this the most current address or phone number or property for a member? Is this the most current medication list? Is this diagnosis accurate and associated with this member currently or in the past? We have to move beyond that now that the information blocking and interoperabilities are live. Rules are live, because now we need to talk about data tagging for an individual. HIPAA has not gone away. Providers and payers still have all of the same rights to data across treatment, payment, and operational use cases. But when consumers use their patient right of access and they draw data down into their own data streams where they can control them inside a trusted third-party application, they have the ability to consent and share whatever data they want to at whatever data element or detailed level that they want to. And so it's important for us to know what data is accessible through HIPAA, what data is consented to be shared, when consumers have the right to be forgotten. How long was that data shareable for? And what can we use today and currently? Trying to do a point-to-point-to-point integration to push all of that logic into core databases that exist today is very problematic, difficult, and almost impossible to do. So the concept of an open secure data model that embeds digital identity verification, advanced patient matching, and has the ability then to tag data for use across multiple different business models, partners, pathways, all with consumer consent or under the guise of HIPAA, is where healthcare is headed, because it allows you to be auditable, to be more secure, and also, quite frankly, to make it faster for you to adopt new business models and to bring those outside service partners in. So once you have a unified open secure data model that is standardized, we at b.well solve this problem by standardizing everything into a FHIR format, regardless of what format the data comes in or what system we're connecting to. But then it allows you to have that normalized longitudinal trend line that can create a consistent set of APIs out. The consistent set of APIs out allow you to do a couple of key things that we're going to talk about now. But one, it allows you to do the consumer activation we talked to. Real-time interaction in a consumer's life through text message, push notification, email campaigns, all securely, of course, and with the consumer consent, but preferentially getting to somebody the way they need to at the time that it matters. But also servicing technology solutions that can be helpful to someone inside of their healthcare experience. So when you can see a family's real-time health information, you can create use cases that look like, hey, I see you have a child that was just diagnosed with asthma. We have a partner in Propeller that might be helpful for you and your family to manage his condition in between doctor's appointments. So we can start to surface and match digital solutions to individuals at the time that it matters and the time that they're seeking help, which oftentimes the biggest change impact that we've been able to measure from a consumer perspective in either behavior or adoption is at the onset of a new diagnosis. So being able to get to them in real time with support and having the consumer feel like someone has their back is really important. So it's not just education and actions we want to drive, it's matching to solution partners or providers that conveniently fit into someone's life that can help manage their healthcare journey in an easier, more simplified way. So I know we're talking about, over the last couple of years, digital front doors, and digital front doors are very important, right? But we're not here to help the lines at Blockbuster go faster, right? We do need to digitize. Absolutely, hands down, consumers expect it. If you do not have a digital front door that is seamless and easy to work with, consumers experience friction and they will go somewhere else. But what we're talking about here is the consumerization of healthcare, which moves well beyond a digital front door. And what it does is once you have that digital front door in place, you can start getting out and being more proactive with partner programs. You can bring the outside in. Imagine all of the great, tools and technologies. We talked earlier about CVS opening up its SDKs for booking an appointment at MinuteClinic. A partnership with CVS would allow you to start bringing that inside. So if you were in a value-based measure, or you were being measured on a value-based measure for convenience of care and consumers feeling the sentiment they got it, if you know that you are at capacity and you simply can't hire enough doctors fast enough, that partnership might help to solve for your value-based arrangements. So if somebody was unable to book an appointment with you, could they leverage that open SDK kit in order to help book an appointment through a partner program in order for you to meet that need? So think about it as building a healthcare delivery model that sits around the individual using their consent to allow them the convenience measures that they're looking for. And that means not only looking at the services you provide, but looking beyond that to the services that they need as a whole. So you can be that single first screen mobile launching off point for healthcare. So when we think about secure, personalization platforms on an open secure data model, we're not just talking about data coming in. We're also talking about integration to services. So we've talked a lot about developing lifetime relationships and what that means. Giving me something that is so sticky that I don't want to start over somewhere else. That involves aggregating real-time consumer information, not just on the medical and the billing side of the world, but across everything in my healthcare experience, including my social connections, including my wearables, including my goals and objectives, my preferences. Being able to layer all of that into an open secure data model to create logic-based decisions, being able to train models that get smarter over time on a normalized, comprehensive set of real-time data. But when you think about those open API infrastructures and your ability to get out into the market to create the consumer experiences that we've been talking about, enabling choice-based consumer-friendly marketplaces becomes an opportunity for you, where today we talk a lot about point solution fatigue. And point solution fatigue is because there are just too many options. There's 300,000 digital health applications on the US cloud, with 200 to 250 new applications hitting the cloud per day. Now, many of them also don't survive, but it's still a lot of option and choice. But when we think about healthcare buying cycles, we typically budget, and then we think about the biggest problem that we want to solve for. And then we figure out whether or not the solution fits into that budget that we want to bring to the table. But then we start down being unintentionally paternalistic. Because of our buying cycles, we typically will put out an RFI, and then we'll put out an RFP, and we'll take a long time to select the solution that we think is best for the entire population that we are serving. And then we'll go to contracting and security and privacy review. And it's why sales cycles in healthcare are notoriously long. And then we have the implementation, integration, and last mile marketing for adoption. But when you think about an open API infrastructure and the tooling of double-sided marketplaces that exist in finance, in travel, in rideshare, in food delivery, the tooling and the models technologically exist for us to be able to provide better solutions. And so at b.well, we solve this problem not by bringing you a curated marketplace of solution providers, because we know that those solution providers are going to change over time. We actually bring you the tooling that allows you to invite as many of those partners to the table as you want, to sign up and adhere to standardized terms of service, privacy policies, to collect information on high trust and SOC 2 audits, to have your vendor partners tell you who they target with the solutions that they serve. What are the diagnosis codes, the procedure codes, the medications, what are the qualifying demographics? So, and then uploading their own marketing materials so that when somebody's data comes into your overall platform, you can automatically match them to a service based on what that provider is telling you that they can impact. But more importantly, you can stop being paternalistic and you can invite more than one, which means that if we're looking at, pregnancy and maternity and fertility and the whole women's health spectrum, there are so many phenomenal solutions in there. But there are solutions in there that aren't just designed for an entire population. There are very specialized services like Candlelit, which is designed for Black and brown moms in our community, which we know have very different maternal health outcomes than white women. That means that by offering more and not putting out that RFI or RFP to pick just one, that we can offer choice-based solutions to individuals, not only helping to improve diversity, equity, and inclusion, not just in our companies, but in the solutions that we provide to the populations we serve, but helping people to engage faster, because we know that they want to engage with things that fit into their lives, that look like them, that speak their language, and that are uniquely tailored to their cultures. So being able to create the tooling to move faster that sits on top of that open secure data model actually reduces your administrative expense, it increases your time to market, and it improves your choice with the commitments to the communities that you serve. So open secure data models are really important because EMRs and payer portals and others, they're just simply not designed for integration of other systems. apps within apps, websites within websites. And I don't mean through SSO and clunky iframes, but I mean true real-time integration through embeddables. That allows you to move to step 5, which is around marketing and testing your communications and consumer experiences with real-world A/B testing. So how do I know whether or not I am meeting someone's need and measuring, how many people are going to go in for the colonoscopy, how many are going to accept the home test, how many are going to want to pick up their test with their pharmacy order, and how many am I still not reaching? But measuring those funnels allows you to consistently innovate and move into a world where you're starting to target objectives and key results and not buying an off-the-shelf solution to a problem that you may or may not have with a solution that may or may not fit that problem. But being able to live test all of them very quickly and determining which ones work within each side of your population. Because I can tell you a little secret, there is no one healthcare solution that works for everyone. And so this allows you a lot more freedom in the framework and flexibility to start to accomplish the key results for your organization. And it also allows you to differentiate and market. But most importantly, you can start to really simplify your technology stack and accelerate your innovation. And so by bringing everything into a standardized, open, secure data model integrated with one another, you can start to figure out how to pull all of the pieces of the equation together so that it is consistent to an individual, that they have the ability to see one experience, even if there are 20 different platforms behind it. But we all know that we go through migrations over time because technology continues to advance. The solutions that we were pushing to population health 10 years ago are not even the same companies that we are talking to today. So when we know that change is consistent, having a platform that allows you to unplug and plug in new solutions without having to re-engage the users that you have in your population through the front end, because you can simply handle the migrations behind the scenes, even if there's 12 EMRs at the table, or 10 different payer systems, or 12 different ACO contracts, or different specialty-based clinical programs. When you unplug one solution and plug another one in, you're not taking away the entire experience for the individual, because they still have access and transparency to their health data. They have real world personalized communications coming to them. They have real opportunities for new partners, new technologies, new programs and services to come to them all the time. And they're connected to their family, friends, and loved ones. It allows us to bring the ecosystem together to start building a healthcare delivery model that is designed around a consumer and their families, and flip this market completely on its head, where we're not expecting them to come to us, but we can start to really go to them. So with that, I want to thank you for your time. I'd be happy to open up to any questions that you have, but would absolutely welcome the opportunity to answer those questions, or even to follow up with you at a later time after the presentation.
Wonderful. Thank you so much, Kristen, for a great presentation today. Like you said, we will now begin today's question and answer session. You can submit any questions you have by typing them into the Q&A chat box on your webinar console. Let's get started with the first question. So we have many for you today. And the first one I wanted to ask is, someone said, what do you see as the most significant trend in consumerism next year?
Yeah, I think the trend in consumerism is there's going to be, I like to call it, the Hunger Games of primary care is afoot. And, that's kind of a humorous way to talk about the fact that their primary care, without question, is being disrupted. And I think that from a consumerism perspective, it's going to force the conversation around convenience. In fact, we know health systems, many of the health systems that we are working with and talking with are debating some really heavy questions around, if you can't open up the schedules of your existing provider network, do you actually invest in and spin up a more clinic type environment where you can guarantee same day appointments? And that is the entire model. And then you have people follow back up with their primary care, with their specialists later down the road. The reason for that is, if you look at the competitive landscape, is that it's shifted tremendously. Health systems are not just competing with the health system down the street. Pharmacies across the board now have a very level playing field when it comes to being the launching off point of healthcare. If you look at the acquisitions and the press releases of where, Amazon, Walgreens, CVS, and many others are, even Walmart are going, right? And let's not forget that 75% of America walks through a Walmart at least weekly. So when we think about their position in terms of the front line of healthcare, there's a reason that they have clinics. There's a reason that they have, holding your place in line from a technology perspective, that they have primary care. Now they're moving into multi-specialty, home care, specialty pharmacy, pharma. They can do and provide more at the top of their license. They can practice more at the top of their license because of COVID for things like vaccination and testing. So actually, if you look at your ACO measures, I think you would be unshocked to see that if you are already starting to take risk, regardless of whether it's full risk, upside or downside, that you actually have, the pharmacies have the ability to close over 90% of gaps in care that are at the center of value-based care measures. So pharmacies can either be your biggest competitor moving forward if you are focused on primary care, or they can be your biggest partner, helping you meet those convenience and consumerism timelines, closing gaps in care, but also being able to create integrated experience, bringing the pharmacy inside of the solutions that you offer, but also allowing your services through those partnerships to potentially be offered through the pharmacy offerings as well. So I think the biggest thing that I see in 2023 is going to be the shift towards convenience and primary care in particular, because of where the monetization model is going. And if you think about, another use case, and you think that your population, is loyal to you, I guarantee you that when somebody builds out and offers interoperability in a strategic manner where consumers can collect and share their information, one of the first algorithms that anyone who's going after primary care is going to look at is how many people don't actually have a primary care physician. And if you think about people who are my age and older, right, over 60% of us have a primary care physician, whether we like them or we don't, because we were raised in an era where you always had a primary care doctor, you had loyalty, and you went to that doctor all the time. When you look at our, kind of millennials and younger, right, less than 50% of them have a primary care that they are loyal to. And they would actually change doctors from a convenience standpoint based on price, or time that fits into their lives. And so if you notice that somebody's using the ER as a primary care or they don't have one, think about the marketing ability to bring someone in to a local primary care area where you otherwise would not have had the opportunity to target them previously. And so make no mistake, healthcare is moving into a marketing era as well, where we're going to start to measure out, how to compete for loyalty and value. But when you think about the pharmacies and the tech companies that we're talking about that are these new entrants, they built the success of their business on direct to consumer. They know how to create good consumer experiences without friction. So it's time for us to, yes, solidify our digital front doors, but we have to move beyond that into consumer experiences that start to do things on behalf of people. With someone's data, you can say, hey, proactively, right? If you have integrations behind the scenes with great organizations like GoodRx, and you have the payer integrations as well, you can say, hey, your family can save $50 this month by switching from a Costco to our mail order pharmacy. Would you like me to transfer your scripts? And by doing that, you can say, oh, and don't forget, let's just say we transfer to another pharmacy. Don't forget to use your manufacturer coupon and pay cash because it's less expensive than your insurance benefit. There are easily eight systems that need to work behind the scenes to be pushed together in order to create that experience. But from the consumer, they're thinking, wow, that's a really great experience. Someone's trying to save me money, and they're trying to make it easier for me to access my healthcare. If you also happen to have a social determinant survey where they lack access to transportation, you can connect into the delivery model of either Amazon's PillPack or Walgreens' partnership with FedEx. And so building these partnerships towards consumerism is going to be absolutely what you'll see in 2023, along with bringing together multiple different point solutions in order to meet a more holistic goal of what consumers are looking for, because that's where the monetary drivers of value are going. And technology is now going to give us the ability to speed to consumerism and to start to really move towards real value-based models.
Wonderful. Thank you so much for that in-depth answer. And then the next one I wanted to ask you is, someone said, it feels like we've been talking about interoperability for decades. What's different now versus 2 years ago?
Yeah, that's a great question. So yes, I think we're all tired of talking about interoperability, right? But the rules that went into effect from ONC and CMS, they are sister rules, almost identical, called information blocking and interoperability, are why now. It really did require a change in the federal regulations to give consumers the ability to draw their data outside of HIPAA and share it. And why that matters is because pre these rules, the only way that healthcare data could be shared between entities, even payers and providers, was to enter into a contractual relationship with data use agreements and BAAs. So now we can take away the B2B relationships, because you would effectively need to have, let's say, a United Healthcare having a business model relationship and contract with every single person who might need data from United Healthcare. It just becomes too complicated. So by allowing consumers the basic right to their information, and they get to decide who that information is shared with, you don't need a contractual obligation. So there are third-party applications like b.well. There are others like One Record that have the ability now to not only gather consent from an individual to go collect and access all their data, but I don't need to have a business relationship with every payer and every provider in this country to pull their data in. I do need to have their consent, and I do need to give them the right to turn off and be forgotten anytime they want, which we do. But the reality is that consumers want their data shared. In fact, CBS just published a consumerism survey not that long ago that I thought was very well done. But it basically said consumers want their data, not because they want to see it or interpret it, but because they want to share it. And over 80% of consumers want every doctor who treats them to have access to their whole medical record, not just their own experience with that doctor. So we are in an era where not only were the rules put in place with very stiff penalties, so should someone fail to provide a consumer the right to their data through the open API infrastructure, they can face up to $1 million fine per instance reported. So there's a very heavy stick for non-compliance. That data also then basically pulled the industry together. And there's some really cool groups like the Karen Alliance, as an example, that has created private-public partnerships between big tech, health systems, payers, the government, third-party applications coming together to say, okay, if we're going to make this work, how do we work within all of the existing infrastructure standards that have existed in healthcare on how healthcare data moves? And how do we create a standard that can be adopted countrywide and, quite frankly, now worldwide? And the creation of the Fast Healthcare Interoperability Resource was brought to the table. And there's a lot of really smart people that worked on this problem for a very long time. But ultimately, it created a normalized standard where all of the healthcare entities providing these APIs were mapping their core systems to standardized data fields with a similar definition. Is it perfect? No. Are we at its infancy? Yes. But we do believe that FHIR is the way that healthcare data will transact across the world moving forward. And so it's much easier to pull in that data and to interpret it and to cleanse it and to make it longitudinal than it ever was in the past. So the short answer is federal regulations and standards.
Absolutely. Thank you so much. That completely made sense. And the next one, kind of going off of that, of your answer, someone said, don't you feel that customers may have issues with their data privacy, given this is around health records and data?
Yeah, it's a great question. So first of all, I personally think it's a shame that most consumers have no idea how many times their data is shared on a regular basis anyway. So they don't know that their, self-funded employers have, separate, teams that are evaluating from an insurance benefit perspective, medical claims. They don't know that there are, that their insurance companies have access to their medical records, which they're entitled to for the purpose of payment, under HIPAA. So I think we're actually moving into a world of accountability, if I'm being honest. And consumers, as you've seen in the public, are no longer willing to put up with businesses that share information, even if they're covered under federal regulations. So there's been a lot of outcry around partnerships with healthcare delivery systems and big tech like Google and Microsoft, where people have been up in arms, like, no, I don't want my data shared with Google, even if it's for the purpose of creating, AI to solve for disease states faster. But they were mad about it because they weren't permissioned to do so. So companies like b.well, we don't exist if we don't have consumer trust. And so we are very clear from an informed consent perspective, and we put our best practices out into the wild for other third-party app developers to follow, where we have fully annotated, but also brought down to fourth grade reading level terms of service and privacy policies. But we don't expect people to go into lots of legal language and pages. We make very clear, we do not, sell your data. We do not, de-identify, and aggregate your data. We will not advertise to you based on your data without your consent. You always have the right to be forgotten. Your data will not be shared unless we transparently tell you what was shared and with whom after your consent. So I think that, believe it or not, this is healthcare's opportunity to build trust with consumers and give them more control of their data that, quite frankly, they don't have today, and they get furious about when they find out about. So I think this gives consumers more control, and they can always say, no, I don't want my data shared, or I don't want these items shared, or I want the right to be forgotten. So maybe I've joined a weight loss program that I thought might work for me. It's not working for me. I want the right to be forgotten. And if you standardize those terms of service and privacy policies, you absolutely have the ability and right, those third-party solutions now have to be able to downstream protect the data and delete it upon the user's request, just like b.well does today. So I think we're in an era of accountability, and I think there's a best practice that can be followed that will bring consumers trust in an area where they just don't have it today.
Thank you so much for that answer. I think we have time for maybe one or maybe two more questions. So the next one that I have just got in, and they said, you mentioned financial institutions and other institutions offering interoperability for consumers. However, customers typically own and control their own data through a brokerage of their choice. Do you ever see a scenario where patients actually use their own health data and control what goes in and what comes out?
Yeah, it's a great question. So, the new federal, rules do provide consumers the ability to pull in and see their data, right? And so one of the things, as this is new and newly emerging, that you're going to notice is that there are errors in that data. In fact, one of the top academic institutions in the world has my daughter in her medical record marked with an enlarged prostate. Well, that would be a true medical miracle, right? But the reality is that more and more consumers seeing their data are going to want the ability to correct that data. And today, FHIR and the APIs that come in, that they are not bidirectional, in that consumers have the right to correct medical errors through the FHIR standard, i.e. through the applications that they are choosing to aggregate their data. That will come. The industry and the very smart people working on these standards are working on that as a problem. And there are great work groups that are trying to push that through. But all of these changes take time, because actually under HIPAA, consumers have always had the right to correct their medical records and request changes. But because they don't and haven't seen them for the most part, there really is no operational process at a health system, in order for that information to go back in and be changed. And so things are very administrative and cost prohibitive, for that. So there are going to be advancements where consumers are going to ultimately be their own system of record. I know when I pull in data today aggregated for my family, there are medications and diagnoses from doctors that we haven't seen, in quite some time, that are no longer relevant. So trusted third-party applications often give consumers the ability to say, no, I'm not taking this medication any longer, so that they have an accurate med inventory. So when they walk in the door at the doctor's office, one of the biggest value propositions is, hey, you've summarized my data in a way that makes it easier for me to fill out that form. And now it's exciting because a lot of our health systems are allowing us to automate those check-ins. So just like you check in for your airline flight, you can check in for your doctor's appointment with your known information. And there's a reconciliation that happens there. But FHIR right now is not bidirectional, but I think that it will be. And I think that it will be, in the next 5 years, hopefully sooner. But it's a hard problem to solve from a standards perspective. But I think there's a lot of really great people working on it. And so we're watching that, and we'll be one of the first to adopt it. But I think until we get to the ability to change data on request of patient, and have physicians be able to sign off on whether that change is appropriate or not, because a lot of times consumers may just not have the health literacy to know that something in their record is in fact accurate. Until we get to that bidirectional process, I don't think that consumers can say that they truly, own their record. But I do think that we are now in a state where they have the ability to create the most current and accurate record across their entire healthcare data set.
Yes, thank you so much. That is all the time we have for today. So I do want to thank you, Kristen, for an excellent presentation, and b.well Connected Health for sponsoring today's webinar. To learn more about the content presented today, please check out the resources section on your webinar console and fill out the post-webinar survey. Thank you for joining us, and we hope you have a wonderful afternoon.
Thank you so much.